Hello, and a warm welcome, everybody, on this rather cold winter's evening to EPR Masterclass number 5. My name is Dorothy Bean, and I'm the Chief Nursing Information Officer in the South West region, working for NHS England and with Natasha Phillips's team. And I'm delighted that everybody could join us today. So, as ever, we have 3 amazing speakers who I will introduce shortly. And also, as ever, I'm supported by Sam Sellick, who is my deputy in the southwest of England in NHSE. So I'm going to say a few words about where the idea of the masterclasses came from. I'm going to talk a little bit about the sessions that we've run already, so the 3 sessions that we've run already, and then I'll introduce our speakers. So just a few words about the EPR Masterclass. Many of you'll know that there is a frontline digitisation programme underway, and because of that, there are going to be many organisations who are adopting EPRs for the first time. And I certainly noticed in the southwest of England, talking to chief nurses, chief nursing information officers, other digital leaders, digital AHPs and midwives. Some had no experience of implementing an EPR and were looking for information even before the process started. So they were going to be well equipped for when they really got going on their EPR journey. So the idea of the masterclasses was born in the southwest, but then linked up with our teams in colleagues in the southeast and London, and then we opened up the masterclass programme nationally. And here we are. Next slide, Sam, please. So the sessions are very much about aiding your preparedness, your personal preparedness for what's to come. You might already be partway through your EPR adoption and implementation programme, but I hope that there is something in these sessions for everybody. But a little bit about what we've covered already. So our first session was about the EPR journey end to end and what to expect. Key messages that came out from that was about being clear about the benefits that you hope to get from your EPR system at the outset, and the absolute importance of having early clinician involvement in the planning and procurement part of your process. Then we had a session that was about go live. The things that came out of that was about the involvement of your executive team, fundamentally critical to your success. The importance of supplier relationships and really building those relationships with your suppliers, and the critical role of a well-managed cutover and command centre managed go live. So these came out really, really strongly through these sessions. And in session 4 last week, well, all of you will know that if you're going to run any large scale change projects, that it's important to really win the hearts and minds of people in your organisation and take them with you. And we talked about understanding the motivation behind individuals to take on this change, their capabilities of taking on this change and their capacity to take on the change, as well as thinking about what was in it for them, what are the opportunities for them and their team. So these are some of the things, some of the headlines that have come out from the sessions already. Next slide. Then it takes us to, and I'd like to introduce our speakers today. We have Mel DeWitt, who's Chief Nursing Information Officer in North Bristol. We have Sarah Newcombe, who's a CNIO at Great Ormond Street Hospital and for the London region also, and Simon Noel, who's a CNIO from Oxford University Hospitals. So welcome to the 3 of you. and fantastic that you could join us, and we're all waiting with bated breath to hear the stories that you've got to tell us of your own optimization, which I suspect isn't necessarily complete. I'm sure it's probably going to be like painting a bridge. It's something that just keeps going. Next slide, please, Sam. So we're going to start with Mel. Mel's going to talk us through her experience from a North Bristol perspective. So over to you, Mel.
Thank you very much, Dorothy, and good afternoon, everybody. So we are going to approach this topic of optimisation through looking at the 3 case studies of our organisation and picking out our key learning. And so I'm going to start. I work at North Bristol NHS Trust, and we're really quite early in our optimisation journey. So I'm going to talk about the case for optimisation and the importance of planning for it from the very beginning of project initiation. And then I'm going to share some models with you that we found really helpful. Can I have the next slide, please, Sam? Thank you. So this big shiny hospital is North Bristol Hospital as it is today. And we've been through 2 big changes in the last 10 or 12 years. One is our electronic patient record, and the other is moving into this building, which is called the Brunel building. And there are some really strong parallels between those 2 things, which I think highlight the case for optimisation. So the 2 little pictures, one is Frenchay Hospital at the top, which was opened in 1921 as a TB hospital, and below it is the old Southmead Hospital, which was opened in 1902 as a workhouse. And in 2014, we moved in both of those hospitals into our new Brunel building, 850 beds, 75% single rooms with ensuite, really, really smart and swish. And it was the biggest peacetime movement of patients ever since the Second World War. So really, really big undertaking. We moved 2 ICUs, 2 CCUs, an emergency department and a minor injury unit, and it all went really, really smoothly. And we were very pleased with our planning. And then the unexpected things started. So we'd had, between those 2 old hospitals, we'd had 200 years of optimising processes. Everybody knew what they were doing, everybody knew what their role was, everybody knew how it fitted together. And suddenly people had to learn new behaviours, new roles. All their automation of what they did when they came into work in the morning was completely gone, and everything seemed to take longer. Things didn't work properly. So we had people who put the buckets out in the old buildings when it rained and the roofs leaked, but nobody knew whose job it was to put out the wet floor signs in our big new atrium with its shiny floor. And so the need for optimisation began. So building a new hospital building or implementing an EPR are both technical problems. If you start with a good plan, you can deliver it and you'll end up with what you plan to build. But actually optimising the system, both for running a hospital and for an electronic patient record, are adaptive problems. So there's no real clear causality. You can change something, but you don't necessarily get the outcome that you think you're going to get, because it's filtered through every single individual within the organisation who's working with the system. And solutions are emergent. You can't know everything when you start. You just have to learn it as you go along. From the outside, it can look really simple, but you need to go through that learning process of planning and trying things and testing them and then relearning. And everybody in the whole organisation has to learn new habits and ways of working and different ways of prioritising and different ways of understanding what their jobs are. And so it's really, really important to plan for that from the beginning. You need to give it enough time, you need to give it enough resource, and you need to think that it's going to be, as Dorothy said, a bit like painting the 4th bridge. It's not something that's just over after 6 months or 12 months, it's an ongoing thing. So one model that we've found really helpful at North Bristol is this human factors model from Shorrock. Now, I'm sure lots of you will have seen it before. So if we just think for a minute about how it applies to an EPR optimization. So work as imagined is our vision of what the EPR is going to be like. So when we procure it and we sit there and we think it's all going to run like clockwork and it's going to be smooth and people will do as we expect and we'll get the outputs that we write in our business case. And then we try and do work as prescribed. So we write our standard operating procedures and we do our process maps. And we've got a really clear and detailed understanding of where we want to go. But we know that in EPR land, as well as in the real world, work as done is really, really different to what we think it's going to be. And what people tell you, work as disclosed, tends to be what they think you want to hear and not what they're actually doing. And that can make it really difficult to get the benefits out that you intended. So one of the things we've discovered is that our goal is really not to worry so much about what we imagined it was going to be like in the beginning or what we wrote in our standard operating procedures, but to think about what are the benefits we're trying to achieve and how can we work with our organisation to make sure that work as done is as close as possible to delivering those benefits, whether they're for quality and safety, whether they're for data collection, or whether they're for cost effectiveness. And it is all about going through those learning cycles and driving out the benefit. So the final thing I want to share with you is this workarounds map. So work as done, as we all know, is absolutely full of workarounds, and we have found them really useful to categorise them in these three ways. So the first one is necessary workarounds. So these are where our colleagues in the organisation develop a workaround because the system doesn't actually do what we think it's going to do. And we had a really good example of this at North Bristol around elective admissions. We thought it would work, and when they tried to run it, it didn't work in quite that way. So our solution to that has to be to review the system and redesign it. And then we have innovative workarounds. So this is where the staff develop new and clever ways of doing the work that we never imagined or planned for. And those are a massive learning opportunity. So if you find a workaround where someone's developed something new, then you need to evaluate it and learn from it and share it. We had a great example of this afternoon. We've got a process in for reserving beds that's 25 clicks. And one of the wards has started using another process for closing beds, which is 3 clicks. And so we are going to add another option for closing beds that enables you to reserve beds. And they have found that themselves. We would never have thought of it without working closely with our colleagues. And then the final one is the tricky one. So harmful workarounds. This is where the workaround that staff have come up with don't necessarily deliver the required outcome, and they might actually introduce risk. And these need designing out or training out, ideally designing out, because it's much easier to stop people doing something within the system than it is to change people's behaviour. And a good example of this would be people not following the right bookings process, and so patients are lost to follow up. So in summary, it's really, really important to view optimisation as a continual learning cycle and a quality improvement strategy, but to plan for it from the beginning in detail so that you have the right resource and the right time frame and you're managing the organisation's expectations. So thank you, and I'm going to pass on to Sarah. Thank you very much.
Thanks, Mel. It's really great to hear that nurses are innovative all over rather than just in certain areas, and I always think of it as an innovation rather than a workaround. It's quite a nice concept. So I'm going to tell you the story of Great Ormond Street Children's Hospital and our EPR journey, and really what we've done around the optimisation piece. So for those of you that don't know, GOSH was opened in 1852. It's a tertiary and quaternary, never get that word right, referral centre for paediatrics. It's also a research and teaching hospital. And when we started our journey back in 2017, looking at opportunities for an EPR, we thought one of the things we really needed was an innovation hub. And so we approached our charity and set up something called DRIVE, which is Digital Research Innovation Virtual Environment. And I'll talk a little bit about that later. We call ourselves small but mighty. I think that means we're just in the spotlight, but we see over 240,000 outpatient appointments per year, with about 43,000 inpatient activity episodes. 63 different clinical specialities, which brings its own challenges, and certainly when you're building an EPR, and just over 400 beds with around 4,500 staff. A significant about 1,800 of those are nursing, so it's quite a big workload. Next slide, please, Sam. So for me, an EPR programme is a clinical transformation programme. Don't ever see it as an IT project. And I think that message was given to me by colleagues before we started our journey. You need IT along with you, but actually this is about transforming your whole organisation, and it needs to be owned by the organisation. And if people feel like it's being done to them, it's very difficult to bring them along with you. We focused mainly on patient safety and the experience of the patient and the staff, and so we had lots of open forums for staff and for our patients, which really helped us along our journey. And I just put in here about focusing on cost savings. People, certainly when you're putting your business case together, want to know what the cost savings are going to be. And I would really argue that those aren't really going to happen in the first sort of 12 months, certainly, of an EPR implementation. It's much later on that you start to see your cost savings. It's really about safety and that wider approach. We went with a mile wide, inch deep, as we called it, approach to configuration, and I think that was a wise thing to do in terms of we built the bare minimum, and that enabled us to allow the organisation to then get familiar with their EPR system, to start identifying ways in which they felt they could change the system, and Mel alluded to one beautifully earlier. And that's really helped us in terms of engagement, but it's also meant that the system has been built by the end users rather than by IT teams. So this just tells you just a good picture of our epic EPR journey, the groundwork phase right the way through to go live, which was in April 2019. I wanted to point out the stabilisation piece, which we did for 3 months, which is key and must be in there before your optimisation piece. But we had 14 months of optimisation built into our programme, which provided us with really good opportunity. I don't think any of us planned for COVID in the middle of all that, so we did lose a significant amount of that, but it did actually enable us to develop and use the system during COVID in terms of our COVID treatment of patients and so on and so forth. So just in terms of the stabilisation piece, I think it's really important that you build this into your business case. The 3 key things that I've picked out of there are your issue resolution. So there are issues when you build things aren't built quite right, and you do need a team there that's able to pick up those issues and fix them in a fairly swift place. In those 3 months, we actually did a lot of our optimisation planning, and that was key because people came to us with what they thought needed to change and what we could do that would optimise the system. What that actually really helped us with as well was ongoing training and support where it was needed, because I think we got a lot of feedback that things weren't working, but actually it was the training piece that was missing. So it's another really good way of having those communication lines open. I just wanted to put this in about optimization governance, and I think it's really important that you have a clear governance line once you put that EPR in, and we've all spoken really about this being a journey. The go live is just the beginning for me, and the optimization is really more important than that, and so it was quite key that you have that governance structure. There's a couple of things in here that I'd like to point out, and these are our sort of EPR advisory groups, and they were critical to setting up what we were going to be working on in optimization. What we quickly found out within those that we actually needed nurses in all areas who were going to support some of these optimization plans and feed that information down to the local teams. So we've set up what we call TCLs, so transforming care links, and I'll talk a little bit about those on the next slide just to give you all some ideas. So in terms of optimization focus, the key areas for me for focus are really around the business plan, and I think we've all said the same. Ensure it's written into your business plan. Establish a team, and that means not a team just to go live. You may find you need more nursing team support to get you to that go live point, but you really need to have a nursing structure and a nursing team led by a CNIO, but I am lucky enough to have NIOs within my team who help deliver with all that optimization piece. In the optimization planning, we did something called tranche planning, which was 3-month cycles. So we had key deliverables in all of those cycles. So it made it easy for us to describe to the organisation what we were optimizing, how we were going to deliver, and what we expected to see at the end. And we found that really helpful in terms of setting the standards for our teams. What we saw that do was increase the quality and volume of system design. So people started then to get really interested in what we were doing and became more engaged. Data usage, and again, I'll speak about that a bit more later, but we really need to understand the need as nurses. And I think that's a new way of working in that digital space. But it is key to how we move forward with our care delivery. System upgrades, it's really important to put these in your optimisation planning. These are when the system has to be upgraded. There's quite a bit of work around that, particularly around the analysts, but there's also quite a prep piece for the organisation because they will be without the system for a number of hours while upgrades happen. We put those in quarterly because it's not such a big bang. Quite a lot of people have more than that or longer time or a year, but actually when you mount your upgrades up, it's difficult in two ways. One, for the analysts, because they have to do it all in one hit, whereas they could continually do pieces of work to get them to the next upgrade. And then also for an organisation, they just get used to being without system, and it tests your business continuity planning. And then the operational teams bit, which is the transforming care links, which I think is on my next slide, please, Sam. So what we did for this is we looked in our organisation, and a lot of these were SMEs or floor walkers for our go live, but we identified individuals that had a passion for making improvements, and you found them across all the organisation and sometimes in places where you don't expect. But those that have a deep clinical understanding of the workflows within their area and an ability to work as part of the team. And they needed a little bit of technical skills as well, but it was really helpful. How did we entice them? So we gained digital experience. So they came in working some time with my team to understand how we did that and how the process and the governance behind an EPR works. We gave them the opportunity to learn new things. We did little things like we gave them VIP status when they were calling the help desk, which meant their calls get answered first. So it also gave us that central piece that the calls came through to from one person who had an understanding, and sometimes we found that the questions were sometimes filtered out beforehand. It gave them education opportunities, like I said, internally within our team. We then started some coaching and mentoring for those that want to continue on that journey. And we gave them the opportunity to do the Lean Six Sigma Yellow Belt training to help with that. It was created by one of our consultants, a digital platform, which obviously then came without charge. So that was quite good. And we also gave some of them the opportunity to do EPIC clinician training. And that means that they were able to then build within the system, which many of them were excited about. But it helped that we've got the end users then, in the system, really understanding what some of the challenges are. So just in terms of data usage, I just wanted to call out really that there has to be an understanding of the importance of the data, and what you put in is what you get out. And it's important when you're building that you don't fill the system with hard stops. It's really important to change the behaviour and not the system. And for instance, things like EDD, when people are putting estimated data discharge in, that they understand what the output of that is going to be. Real-time data for nurses. So it's quite different in an EPR in terms of the data is happening and you get a snapshot of what's going on in the organisation or a clear picture of what's going on in your ward. That sometimes proves quite challenging when you have kind of data within third-party systems, and an example of that is our server as something called Kabuda, which is the back end where data is then stored. That's 24 hours behind your live system. So when people are pulling data from that, we do our ward accreditation, for instance, it then becomes data that you can't challenge on the ward because it's yesterday's data. So it just takes that mind shift for people to really sort of start understanding where their data is and how it can improve their care and the outcomes. Some of the smart things around the data are things like sepsis workflow, and we start looking at things like cognitive computing, which looks not only at what's happened to the patient previously, but what's going to happen to the patient on that shift. And it really starts to shift nurses' mindset as to how they're caring for their patients. Oh, it's over to Simon. So I think just as a quick recap, if that's all right, Simon, make sure it's in your business case, build a team, post go live is just as important as go live, and understand what the data means for you and your teams. It's really important. Documentation by exception. Documenting digitally is different, and we do really as a profession need to change that culture. Now I'll hand on to Simon.
So I'm just going to intervene for a moment, Sarah, because we've got a couple of questions come up, and they've come up while you're speaking, so they might just be to you. So if I can put these to you, you can probably see them in the questions and answers. So first one was there resistance from the EPR supplier, RE end users designing the broader elements?
No, absolutely not, actually. We were very lucky with the team that we had that came to work alongside us, and there was very much a collaboration. I think, as many of you know, Epic is a US product, so it's quite different how they work in the US as they do to the UK. So some of the challenges were around, workflows, but they were willing to work with us, and it really was a genuine partnership. So, and we continue that journey. We still have them on site on a regular basis, trying to understand our workflows and help and support and change and develop things.
And one other question just for now. I know we've got another one sitting in our chat. It says, I highly appreciate the EPR journey shared by the different trusts successfully. Can I ask, what are the main challenges you found during the pilot or systems testing prior to go live and stabilisation of the EPR?
Yeah, no, I think that's a really good question, and there's quite a lot, and I could do a whole new presentation on what some of those challenges were. I think for us, one of the big challenges was things like blood workflow, administration of blood, getting that right, and obviously the legalities. We had a lot of challenges around med workflow. Being paediatrics, a lot of our medications are unlicensed, so in terms of barcode scanning, that was challenging, and getting those sorts of things right. Happy to share that on a broader level if people want to reach out, but I think there are similarities in every EPR. It doesn't matter what your EPR is. I think the processes are the same. It's moving everything digitally and moving people with you. We also saw quite a bit of repetition, which we had tried very hard to avoid, but in testing that comes up, that you don't want people documenting in different places at the same time. A lot of that gets picked up in your optimisation.
Thank you. Do either Mel or Simon want to come in that about the main challenges?
I think from our perspective, it was to do with engagement and understanding the workflows. And I think Sarah touched on a point there to do with repetition, because essentially what you want to do is you want to document once and use many times, because by doing that, it means that you have a single source of truth. And it means you don't have parallel silos of information within the record. And sometimes, particularly when you're new into an EPR, people have difficulty understanding the concept. And I think one of the things we found is that a lot of our staff still to this day, even though we've been live for quite a long time, as you can see from the slide, is that they want to summarise and repeat everything at the end of the shift. And that's sort of the legacy of, if you didn't write it down, it didn't happen, and also a legacy of when the documentation was disseminated around the ward and you needed to amalgamate it at the end of the day. And you don't need to do that anymore, because the record is one continuous record in which people are documenting in all the time. So it's understanding the concept, and people understand the change and the workflow. And sometimes that can be the more established and more senior members of staff who are less close to the patient in some circumstances, or less acute, or less undertaking less of the hands-on care delivery on a day-to-day basis. That can be the case. So there's a lot of different environments, and it's winning people over and formulating your team and getting the message out there, I think.
Probably a good moment for us. I know we've got another question. We'll try and come back to it. Probably a good moment for us to hand over to your part of the session then, Simon.
Super. Yes, thank you.
Thank you.
So as you can see on the screen, I mean, the Oxford journey has been ongoing for a while. And just give some context, just to put ourselves into the same picture as Mel and Sarah. I mean, we're a trust of 1,000 beds. We've got 100 different departments, got 4,000 nurses. We have like 75,000 emergency department admissions each year. So you can see we're a big, diverse and busy organisation, and putting an EPR into that organisation, making it work, was always a big challenge. The timeline you can see in front of you is just indicative of some of the key milestones that we've had across our journey, and you can see that it's there's been a lot of things going on, and rather than being a big bang or a big implementation like you've seen at the Great Ormond Street, our rollout has been quite iterative and quite sort of a slow burn. So we've had different functionality roll out at different times. So we've had different phases of optimization happening throughout the lifetime of our EPR system. So it's although our experiences are very similar, the circumstances are subtly different from what we've seen in other organisations, the other two organisations we've seen this afternoon. So what do we find better optimization? So Sarah's talked about the establishment of the teams and understanding the workflow and building up on what's going on. And Mel's talked about the optimization across different hospital sites and learning and iteration, this sort of thing. But what do you put in place to support that? So as Sarah's mentioned about the team for a go live and the team for optimizing, and this is to build on that. So this is some of my team who work here at Oxford, and the organogram you can see in front of you gives an indication of my role and where I fit within the organisation and how my team support the organisation on a day-to-day basis. And it's about understanding the presence of nursing within the organisation, understanding how we adapt and how we fit as part of that change process, and how we can interpret the needs of the organisation and translate those into technical changes and to organisational workflow optimisation. My role is very much tied in with our Chief Digital and Partnership Officer, but also I have a very close working relationship with our Chief Nurse, which means that on both of those fronts, I have input and I have say in not only the organisational strategy for digital, but also the organisational strategy for digital within the nursing strategy as well, which gives me the opportunity and gives us the opportunity of putting digital on a platform which meets the requirements of the organisation, but also gives it the impetus and the standing it requires to get the change, get the foothold, and get the progression that we need to make optimisation and effective nursing change. So this is just a bit of an indication of some of the stuff we've looked around in our organisation, and we're all familiar with SBAR, we're all familiar with the nursing process, we're all familiar with the way that we implement that. And this is we want to use this as an example of what we need to do on a day-to-day basis, not just at the start of the process, but also throughout the process of optimisation and the longer term support of our EPR systems. So if we're looking at nursing, what does nursing look like within your organisation? How does it work? Where does it fit? Who do you speak to? What's your senior nursing, or what is your senior nursing dialogue like? Where do you, as a nursing digital leader, sit within your organisation, and how much can you interface with the other departments and the other specialisms within your organisation? When it comes to nursing, it's not just what it looks like, but who's going to lead it. Who is the owner of the nursing process or the nursing documentation or nursing implementation within your organisation? And for us, it's very much our chief nurse. She is the one who is accountable and responsible for that. But I, as a digital nurse specialist, are the one who help to interpret that need and interpret the technical need into the nursing clinical outcomes. So it gives me the opportunity to work on both sides of the fence and help to optimise that with the nurse specialists across the organisation. And in the same token, who's going to own it? So if there is function, if there is change, if there is workflow, it needs to be owned by the clinical teams. It's not a digital service. Now, one of the mistakes that is sometimes made, and it's been made in our organisation more than once, is that, oh, we're putting this change in, oh, digital will do it, or digital nursing will do it. And actually, no, the clinical teams need to own it, because if they don't own it, then adoption is always going to be very poor. So it just needs to be very aware of who's managing and who's interfacing with your team, and making sure they're accountable for what they're asking to be put in, and they own it and make sure that it evolves and develops appropriately. And you need to be able to measure what you're doing. You need to find out what difference the changes, the workflows, the documentation, the training, the education, everything else that goes in there, what difference does it make? So you need to measure what you're doing so you know what the benefits are and what the outcomes are like. So we need to pull out data now. Sarah very eloquently talked about data and data optimization and what that looks like on a day-to-day basis. And our process is very much the same. And I want to mirror that as being very, very important, because quite often it's forgotten. If you forget about, if you put a change and you don't measure it and understand the effect it's had, then you won't be able to understand whether it was a good change, a bad change, or whether it's been done appropriately or not. And when it goes back to what Mel was saying at the beginning of the presentation about the effect of an optimization or a change and the way it affects the organisation, this is the way you find out. So a couple on here, we have a couple of dashboards from our reporting system, one to do with our positive drug ID workflows for our medication administration. The other one is for care plans and the care plan usage. So what we've done is we've taken that information and we've made it available to the staff at the bedside, which means that the nurse managers can see what's happening on a day-to-day basis, and they can own that data and they can work with it in order to understand the benefits and the safety that effective use of our EPR system is bringing about. So, I mean, it's having this appropriate data in order to get this, of course, and again, Sarah mentioned this quite eloquently, that the nursing voice is essential throughout this process. And this is where I and my team come in order to make sure that it works appropriately. And showing the benefits of investment is always important, because you need to show that the amount of time, effort and money you put into putting these changes in is going to be worthwhile, not just for the financial benefit, because that's going to be much further down the line, as has been mentioned before, but also it's the safety benefit and the optimization benefit, and it's the addressing clinical incidents and facing down issues and making sure that we prevent patient harm. So now this is a little bit more complicated than the slide Sarah put on about the oversight and the governance, but it more or less, if you look closely, everything that Sarah was putting about the governance and the oversight appears in here. We have divisional digital groups who have their own oversight process, but most notably we have our clinical advisory group, we have a design authority group, we have our digital oversight group, which oversights the entire program, and nursing has a presence in all those agencies and all that governance process. So it means that we have a voice, we have a place to say what is right for nursing care within the organisation, which means we're not segued to the side somewhere. We are able to make appropriate change and make positive impact on patient care on a day-to-day basis and show the benefit of what we're doing. And on that note, that's all I've got to say. I think next slide, Sam, comes to our end slide. There we go. So there we go. I'll hand over back to Dorothy to see about discussions and questions, but happy to answer anything, but within reason.
Thanks very much. Really interesting summary, and I can see, as I'm sure everybody can, the complexity that is in those governance processes that you've showed up there. There is a question, another question. It came from when Sarah was talking. So, and I suspect, Sarah, this one is for you. So there's a question in here that says, could you share more on your Lean Six? So this was something that you'd mentioned. So, and we've got a few minutes. So if you can, happy you spend a few minutes talking about it.
Yeah, So I think the Lean Six Sigma is quite a well-known thing, actually. So if you look on the sort of internet, you'll be able to find many sort of definitions of it and courses that are to cost. I think what we used it for was that whole dangling a carrot piece. So how are we going to entice people in? What we're going to offer them that wasn't going to be a huge cost to us as an organisation. And so, as I said, we were quite lucky in that one of our consultants built out a Lean Six Sigma program. I'm very happy to share it with you. It basically is a methodology about a collaborative approach to how you're going to improve performance. So for me, it was all about getting the people that we were going to work with optimization on the same page. So how they were going to bring their issues and concerns and how they were going to articulate them was quite key to how we would then be able to move forward and deliver things. And so what we found it did was reduce our variation. So it was really helpful to sort of just put these volunteers on this course, and they came away feeling like they'd benefited from something. They got a certificate at the end, and it was a really good process, and we got some fantastic feedback on that. So as I say, happy to share the links as to what we used, if I can dig them out, but it's also available on the internet, which will give you the idea behind the process of the methodology.
That's great. And if you've got something that we can share, we can send it out to everybody when we send the evaluation form out tomorrow. We've got another couple of questions, and this one might be for everybody, including for Sam, who's been quiet throughout, but I know this one is close to her heart. So the question is, would the experience and process for implementing an EPR differ greatly if it's not for EPIC or Cerner and the trust goes for a modular approach, i.e. an overarching EPR pulling in from many other existing systems? So Mel, you're smiling. I'm going to come to you first. I think you've been there and got that hat.
Thanks, Dorothy. So we are using System C's products, and we are it is a modular EPR, but we are also using other systems that we're pulling in data from. And yes, I think that's a really insightful question. I think the experience and process will be different, and it will certainly involve more complexity around interoperability and getting data out. But I think the principles of what you've heard here today about good governance and planning and the nursing voice will still apply. And I also suspect that even if you implement something like EPIC or Cerner, and I think Sarah referenced some of these, with the complexities around being a paediatric unit, what your experience and processes will be dependent on your organisation. And so there's lots of transferable learning, but I don't think anybody's journey is exactly the same as anybody else's. I think there's lots of variability. We always have to keep learning from each other and supporting each other.
Sam, do you want to come in and say something about this? I know you've been tucked in the back office somewhere, but I know you have this experience, so.
Yeah, I can do. Yeah, so I think I can just reiterate really and concur with what Mel has said in regards to, those core principles will apply. So, needing that nursing team, the engagement, the comms, the governance. But as she said, I think, in regards to the scale and capacity, in regards to the size of that team will very much be determined upon the size and scale of your organisation, the timelines of which you are working to in order to achieve. I mean, Simon's gave a really good outline in his timeline in how he's achieved that modular approach using, multi-systems. So I think, one thing that may increase the need is in regards to kind of clinical safety, in regards to the multi-systems and the interoperability and how that's pulled together to be one cohesive record, maybe more of a challenge with a modular approach. But otherwise, I really concur with what the panel have said today. So thank you.
I'm going to go on to the next question, if that's okay, and then we'll finish off. So the questioner has said, I recently spoke to my CNO and we still face lack of interoperability of different software systems. How did you overcome interoperability problems or minimise the noise of this challenge from the end users? So that's an interesting one. So how did you overcome and how did you deal with the noise? I mean, with that noise, I'm assuming there's potentially also risk and poor user experience. There's quite a lot of things in that question, really. So again, I'll go to Mel first and then maybe Simon and Sarah.
Thanks, Dorothy. So interoperability is an ongoing problem, isn't it? Unless you are lucky enough to have a system that works right across your ICS, it is the challenge that we all face all the time. And I don't know if there is a slick and easy answer to how you overcome it. I think we need to talk to our end users about, well, I guess a journey is a cliche, isn't it? But stepwise improvement. So, you know, we used to run our hospitals on paper, didn't we? And every step towards interoperability is an improvement, and we need to keep talking to our suppliers and working with our technicians to make that better and better and better. And I think your point about noise is interesting. I think we need to take our end users with us and for them to understand that every system is a framework within which you have to work. But I also think we need to hear them because they keep us honest and they keep us with that vision of true interconnectivity and having the patient at the centre of everything we do. So we want them to feel like they're partners, but we don't want to make them so quiet that we're not benefiting from what they're telling us. Thanks, Dorothy.
Thank you. And Sarah and then Simon, would you like to come in? I know that interoperability, when you're running a tertiary centre, as you are, Sarah, presents its own challenges.
Yeah, so it's a really great question, first of all, and I think, you know, as Mel said, it's not easy. It really isn't. Wherever you are, it's not easy. I think there's several parts to it, and the first part for me is that sort of part that's external to the organisation. So whilst you're in central London as a tertiary referral, you're part of an ICS that actually most of our patients don't live within our area. So only about 11% of our patients live within the NCL borough, and less than 50% live in London. So you can imagine most of our patients are outside. So the interoperability of that, how do we share the records that we are using within Great Ormond Street to basically patients' home hospitals, is a challenge. Shared care record is a big thing, and I think, you know, we've certainly set that up within our EPR. There's now a click button that goes straight to the shared care record so that you can see. That's certainly helpful from a safeguarding perspective, so you can see those touch points of where patients have been in other organisations and other hospitals. And there's also kind of a link between, we can set up a link and push some of it really to the patient in a way with their portal, although the feedback for the patient portal is huge because families absolutely love it, and it gives them some ownership of the care that they're delivering. In terms of interoperability internally and the noise, we went from 346 systems down to 9 when we went live with Epic, so it was a significant change. And yes, there was a significant amount of noise and people felt that they were losing an arm and not a way of doing things. And it genuinely, you know, the noise was that loud. I think the point that Mel made really is you do have to sit down and give time to those end users to help them to understand and potentially build what they need within that system. And I accept that it is probably easier with, you know, systems like Epic Cerner that are able to do that in a more robust way. But yeah, people get used to it though. That's the other thing that you know always surprises you. But people do genuinely get used to working differently in about a year. So you've not got long to go. Thanks.
Thank
Dorothy.
you very much. We've just got one more minute, so we'll just go on to the next slide, and I'll just say something about the budgets question. We had a couple of questions there about budgets. So in terms of what happens next with these sessions, the recordings will be available once we've edited them, and we will make available the questions. We're hoping that we'll have a possible workshop to finish off these sessions at the Rewired conference. So I'd encourage all of you that are interested in digital health to come to Rewired. It's a fantastic event. It's free to attend, so please do come along, meet us, join our workshop if we get one. Masterclass number 3 that we had to postpone is on the 26th of January from just after 4 o'clock until 5, and that's about developing usability and stabilisation, if we nick Sarah's word. For all of you that want any help, whether you're inside the NHS or not, you can join the Futures platform. It is there as an EPR community to support practice. I know for people working in enterprises, for example, they are going to be impacted by local organisations and their EPR adoptions. I'd enjoy and certainly welcome you to come and join that community of practice. And just finally, about the budgets, there is a formula for budgets to be costed, for the costings to be undertaken. It is something that is worth you putting in that EPR community of practice, because I haven't memorised them, but I know that documents are available as to the budgets, depending on the type of organisation and the size of organisation. So please do ask that question into the Futures. If you're not in the NHS, that's fine. You can join Futures and ask that question. You can be able to see the formula. Thank you everybody for joining us. We have gone over by 60 seconds, which is we've tried to get them all in. I hope it's been an interesting session, and thank you again to our speakers and for Sam for supporting this event.